Good afternoon, everyone. Thank you for coming. I'm delighted to have the opportunity to introduce our speaker for today, Dr. Chuck Raison. And I wanted to tell you just a little about the context in which he is with us. As many of you know, I'm Dr. Karen Weiss. I work mostly at the Cancer Center, and I do research on how people's mental health is impacted by cancer and generally medical illnesses, and got inspired to think about trying to bring Dr. Raison to the University of Arizona when I found out that he, as a psychiatrist, was collaborating with one of our colleagues over in the Department of Psychology, Dr. Matthias Mell. Fortunately, Dr. Mell is very collaborative, invited me to dinner when Dr. Raison was in town several months ago, and we really found a tremendous amount of common interest and enthusiasm to work together more. There's a mechanism here at the university right now through which we might be able to mobilize some funds for what's called clinical translational science. Many of you might have heard that NIH now is really making a big effort to take what we know from basic science and get it into the clinic and into giving advantages to our patients at a more rapid rate. So if we manage to bring this funding together for Dr. Raison, it'll be in the service of really translating basic science knowledge into better clinical care for our patients. So I'm really excited about the possibility of doing that. And I think you'll hear during his talk why that would be so much fun. Dr. Raison is an associate professor with tenure in the Department of Psychiatry and Behavioral Science at Emory University in Atlanta, Georgia. He's also a guest researcher for the Center for Disease Control and Prevention in Atlanta. At Emory, he is mostly spending his time doing research, but he also directs a behavioral immunology clinic and does a lot of teaching around behavioral immunology and mind-body mental health. On the research side, he is funded to study the mechanisms through which meditative practices have their health benefits. And I like to tell people about his research development, because some of you might be budding researchers, and you should know that if you're currently functioning as a clinician and you've got this sense that, well, maybe I'd like to do more research, there really is a path that you can use to move in that direction, and it's one that both Chuck and I used through getting what's called a Scientist Development Award for clinicians. That's called a K Award from NIH. So any of you who might want to hear more about that, please come talk to me. But Chuck was a CL psychiatrist for many years before getting his K Award, which took him in the direction of being more focused on being a scientist. So it's really fun for me to have him here, and I welcome him to our Psychiatry Grand Rounds. Chuck.
Drive off that would be, that's the kind of thing I'm prone to do. So I am very glad to be here. I'm glad to speak to psychiatry. This is I want to make a preface. This is something of a job talk, meaning that there's lots of things that we could talk about together related to emotional states and inflammatory systems. In this talk, I'm going to talk mostly about the research our group has done. And I am not suggesting that there's anything special about the research. I don't mean to look like a megalomaniac or like a groupomaniac, if there's such a thing. It's just it's a certain convention that people do when they are going around where they try to, blow the horn of the people they've been working with and sort of frame it that way and show how what they've done with the research makes a coherent story. So I don't want you guys to think that studies have to have my name on it to be of any relevance. I'm not doing that. It's just that for this particular talk, you're going to see that there's definitely a focus on the work that we've done around this fact that inflammatory systems and inflammatory processes have taught us a lot about mood disorders, and a lot that many people in psychiatry don't know yet. And so I love speaking to psychiatry because I think inflammatory perspectives on major depression, as I say here, really cast novel light on what causes depression, how we should think about it as a disease entity, and how it might be treated. So, and when do I have to quit, Karen? What time is it?
About 10 o'clock.
Oh, it's great. Okay. So, you know, one of the things that scientific things should do is take disparate things that don't seem to be connected to each other and connect them, sometimes in really surprising ways. You know you're in the realm of myth when things get more and more complicated and things get broken up into smaller and smaller boxes, right? So Copernicus and Kepler were able to solve, and finally with Newton, all of planetary motion with 3 simple laws, whereas the Ptolemaic system to explain things, it explained things just as well, but it required more and more little additions and changes. Now, does that sound like a document we can think of in our field, right? The DSM went from having something like, what, how many, 10, 12 diagnoses in its 3 iteration, and now has, you know, I don't know, 60, 80, 100. This fractionation tells you that you're looking at a system that, while therapeutically useful, and a system that maps onto reality in certain ways, is mythic in the fact that it's not reducing complex phenomena down to simpler explanatory systems that connect across levels of reality. So let me show you how an inflammatory perspective actually, whether it's right or wrong, at least it pitches up testable hypotheses and unifies things. And as an example of this, let's start with a very simple question, which is, why is depression increasingly problematic in the modern world? I mean, we know that depression's been around since antiquity. I've been writing and querying anthropologists who've lived in various tribal societies about what they know about depression in tribal societies, and it's pretty clear to me that people get depressed, that the Kalahari Bushmen get depressed. But we know that depression is something that is becoming more problematic, worsening in the modern world. And so starting in the 80s, there were a whole series of studies that suggested that if you looked at young folks, you found higher rates of depression than if you looked at older people. Now, of course, that may be a cohort effect, but there were these interesting findings that if you looked in families, and this is the 3rd paper, that had incredible loading for mood disorders, and you looked at how likely people were to develop indisputable mood episodes in the 50s versus the 80s, there was a shocking increase in people blowing a fuse in the 80s with at least presumably fairly similar genetic loading. And so all around the world, it looked like people that were younger, like there was an increased risk of depression in general, and that young people seemed to be especially at risk. This was criticized. This is a really powerful researcher in our field, a guy named Greg Simon, and it's interesting that one of his critiques was that it was not specific for depression, so it couldn't be true. And of course, I think that's a misunderstanding of the fact that psychiatric diagnoses flow together like nuts, so you would expect it not to be specific for depression. And that he concludes that, in fact, maybe it's not rapidly increasing, but that it's way higher than anybody guessed from cross-sectional studies, which in a backhanded way also says, wow, this is a huge problem in the modern world. There have since that time been 2 studies here on a national level and here in the United States, though, suggesting that if you, across time, if you administer the same questionnaires to individuals of all ages, rates of depression are significantly higher and becoming higher all the time. There's questionnaires going back now to the 40s, asking about things that are linked to affective temperaments and to depression, and it's been like this. And again, in all age groups. So there's a lot of longitudinal data to suggest that something's up in the modern world that might be that might promote the development of depression. Now, consistent with this, if you take a look at the United States, this is data from the Gallup organization. Every 5 years, they just ask Americans how happy they are, and they have fairly straightforward ways of just asking people. What you can see is that, in fact, levels of happiness have been gradually declining at the same time that gross domestic product per person has skyrocketed. Now, there's a wrinkle to this I'll show you in a second, but it really shows you that money can't buy you love, right? That in fact, despite us living in a world now that has material comforts that have been unimaginable when I was born in the late 50s, far from making us happier, we appear to be more vulnerable to frank depression and, if anything, less happy. Now, this kind of rapid change, obviously, is not due to mutations. It's not due. We know that whole races in America are dying out and being repopulated, so there's nothing to suggest that you're looking at a gross genetic change. What I want to suggest to you is a model to think about this, and one of the things my biologic work has convinced me of is that the environment is overwhelmingly important. But if you take the bar on the left, imagine a situation in the past where environment's stable and you have a certain percent of the population affected by whatever. This actually is a picture from a diabetes article, but suppose instead we're talking about depression. There are some people that have genetic risk. There are some people that are genetically loaded to get depressed if the wind shifts direction, right? I mean, there's some people where they have huge genetic risk factors for depression, and they're going to be depressed in a non-depressogenic environment. But then, say you move to a situation where the environmental conditions have become more commodious for the development of the disorder. And what starts happening is, under those conditions, you start recruiting less and less susceptible genotypes, right? So I might be not that prone to depression, but if you turn up the heat hot enough, there's a point at which almost all of us will crack and begin to manifest symptoms. That's all that's saying. And what the pattern of depression suggests is that there are conditions in the modern world that this is what's happening, right? That we're recruiting people with probably less and less high-risk genotypes because the heat's up higher. Now, I can't remember if I put that slide in this talk, because this is my third talk in 2 days, but there's evidence for type 1 diabetes that this is exactly right. So 50 years ago, you had to have the high-risk HLA genotype to get type 1 diabetes. Now, most people have much lower risk because they're more common, and there are things in our world that promote the development of autoimmunity, as we'll see, and I want to suggest to you that depression is very similar. So I think the word inflammation should be there, but I forgot to change it from white to black. So the short answer I want to suggest to you is that, in fact, inflammatory activities, and here I'm not being overly precise, but I'm saying that there's, as we'll see, a whole bunch of chemicals that we put under this rubric, may account for why we have this explosion of depression. And in fact, if you look at all the risk factors that have increased strikingly in the modern world, they're all remarkably pro-inflammatory. And I'm not going to show you data for that. I'm just going to ask you to take my word for it. But we know, in fact, notice that my social sensitivity, I blacked out her eyes there. I took her off the internet. But we know that these linked factors of obesity and loss of physical activity are both profoundly pro-inflammatory, right? So that if you're not acutely infected, the largest source of inflammation in your body sitting here today is your fat. And it's not just any fat, unfortunately, it's male fat, belly fat. That is a magnet. It's like it's a magnet for macrophages and inflammatory cells. And fat cells produce cytokines also. So there is, of course, an obesity epidemic that follows the adoption of American lifestyles, and there is good evidence we're becoming more and more sedentary. Exercise is a profound antidepressant strategy. It's also a profound anti-inflammatory strategy. Poverty is a risk factor for depression within cultures, especially when it's extreme. It's also a risk factor for increased inflammation. Now, this is poverty rates of first world countries. If you can't read it, anybody want to guess, though, what the outlier that I've circled is? What country has sky-high rates of poverty compared to other first world countries? Ours, of course, the United States. And just to add insult to injury, poor Karen, she's heard me say this now. This is the third time in 48 hours. Poverty is not as bad as the gap between the rich and the poor. That is a depressogenic, it drives depression, heart disease, dementia. It inversely correlates with happiness and education and cleanliness and how the sewer systems work, you name it. And this gap is just, it's a marker that civilization is beginning to unwind. And you can see, if you look at these years, that starting in the late 70s and early 80s, especially with the election of Reagan, actually, you see this giant explosion of gap. And I just heard on NPR here 2 mornings ago that the new census stuff indicates an ever-widening gap between rich and poor. So this is an actively onward process that definitely drives depression, and nobody's ever looked at it that I know of in terms of inflammatory factors, but we know that the United States is also more inflamed than similar countries, right? So there's a great study came out in JAMA by a guy named Banks about 6 years ago showing that Americans, even if you control for all these factors, have higher levels of C-reactive protein, higher inflammatory levels. So this, you know, nobody ever thinks about stuff like this, but this may be contributing. Processed food, we eat the most inflammatory diet ever conceived of or ever eaten. in its balance of omega-3, omega-6. And what you're going to hear me talk a fair amount about today, or a little bit at least, is social isolation, social processes. So isolated individuals have higher inflammatory tone than socially integrated individuals. And we know that social isolation is increasing. People have less friends now than they did 15, 20, 30, 40 years ago by their own admission in the United States. This is another epidemic. We have an epidemic of sort of loneliness in the crowd. And then finally, my favorite, because I have two 20-month-old screaming twin boys, sleep deprivation. If you just want to drive your cytokines, just miss your sleep. So residents, every time that you're on call and you don't sleep, if I were to measure any of these inflammatory markers there, that really does it, right? So, and we know, of course, that people are getting progressively less and less and less sleep. Especially in the United States. So all these factors, you know, if these are all risk factors for depression, and in fact they're all fairly robust risk factors, you'd really be interested in what they share in common. And as I say, one thing that these all share in common is that they activate inflammation. So that being said, I want to focus on stress to start with. And what we're going to talk about is the bidirectionality of stress and inflammation, because psychosocial stress is one of the two royal roads into major depression. And the other royal road, all around the world, what's the biggest risk factor for getting depressed? You know, it's actually maybe stronger than stress. Anybody know? This big study from the World Health Organization came out in Lancet a couple of years ago. USAVA, no? Sickness, right? So all over the world, if you're medically ill, that radically increases your risk of developing depression. You'll see that stress and sickness are very similar to each other physiologically. But let's talk a little bit about psychological or psychosocial stress. And this isn't why it's increasing, but just to give you a taste of how the world's changed and how you can be boiled alive 1 degree at a time. Everybody recognizes what that is, right? United States, Atlanta, right in the middle there, because I pulled it out of the Atlanta paper. So these are streetlights of the United States taken in 1971 by a satellite. Okay, now I'm going to show you the same picture from 2000, because I got this in 2001. So take a look at those nice empty dark spaces, how the cities are nicely demarcated. Now let's see what's happened in 30 years. And Arizona will be much worse. Oh, good Lord. I've been coming to Arizona since the early 60s, and the difference in every single parameter you can imagine is jaw-dropping. I went up to top Mount Lemmon yesterday, and the loss of forest up there, not just from the fire. It's not the same place as it was 15 years ago, which was actually the last time I was there. So many things are afoot, but certainly we know from old studies that if you want to stress out animals, just keep tossing them in the cage with each other, right? And pretty soon they get aggressive, and their rates of heart disease go up, and they develop dementia sooner. So, you know, we live in a world that is novel in every way. Now, having said that, here's an example of some work we did a few years ago that definitely shows, though, that stress is not just a risk factor for depression and anxiety in our world. So I work with the Dalai Lama's people pretty much often, and including his sister, who at that point was running the Tibetan school system for Tibetan kids that lived in exile in India. And she and I cooked up the idea of looking to see whether kids that had escaped from Tibet, who'd been traumatized almost to a person and had lived under a lot of repression, whether they would have higher anxiety and depressive symptoms than kids who were born and raised in the relative sort of security of India. And so this is a really interesting picture because, so on the bottom is depressive, right? So the more you go this way, the more depressed you are, okay? Here is anxiety. The more you go this way, the more anxious you are. So the first thing to say is that in this huge group of people, there's a jaw-dropping correlation between depression and anxiety scores, right? These two are they're twin siblings. We differentiate them, but they always lay down in the same bed. But then, indeed, if you look at the Tibetan children that were born in India, would you all agree that most of the red dots are down in the non-depressed, non-anxious zone, whereas the vast majority of the blue dots are much higher? And so, of course, in these sort of studies, there's always an overlap, but this is hugely statistically significant. And what it says is that, indeed, in other cultures also, if you're separated from your parents, if you're in a foreign country, if you've undergone trauma and stress, you're going to endorse being much more depressed and unhappy. So it's not just here. Depression is a hardwired behavioral response to social adversity, environmental adversity that is inhibiting your ability to survive or reproduce. So let's talk about stress for a second. So let's consider a classic stressor, right? This guy, I saw Star Wars the night it came out, and I knew nothing about it. And that scene, if you remember the movie where Darth Vader first comes, they're playing that, dun, 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 and he comes walking down the aisle. You don't know who he is, but you know it's just bad. It's the best scene in the whole trilogy, I think, because he's so darn disturbing. And so here we go. Here's a stressor, a real clear danger signal from the environment. But of course, for it to mean anything, it has to be picked up by the brain. Now, I didn't say the mind, because there are beautiful studies showing that, in fact, our limbic systems are constantly sort of scanning the environment and firing off to danger signals that the mind can be completely unconscious of. There's these beautiful masking studies that show that you can be completely unconscious of what you're looking at. They can flash horrible things like this, but every time it happens, outside of consciousness, the amygdala fire, right? And depressed people demonstrate that phenomena far more than non-depressed people. You treat them and it reverses. So, but we know that there are danger pathways in the brain, and this is largely, these circuits are largely what Richard studies actually, in terms of these sort of medial, visceral motor, the parts of the brain that assess novelty, assess danger, and then activate systems in the body to cope with it. And of course, the two systems that we think of most often here are the autonomic nervous system on the right and do you guys know about corticotropin releasing factor hormone, right? I mean, it's a big psychiatric kind of thing that has totally failed, by the way, thus far as any kind of intervention, right? I mean, there's going to be all these CRF blockers and they've all gone to seed. But basically, when you are confronted with a dangerous situation, a lot of systems get activated, but the autonomic nervous system and the HPA axis get turned on. The autonomic nervous system, of course, is much more rapid, and the HPA axis is a little slower and is especially sensitive to psychosocial stress and danger. But the net outcome of this pattern is that it does all the things you'd want to do in the face of both acute opportunity and acute danger, right? Focuses attention, sharpens but limits attention, mobilizes energy, shuts down all non-essential bodily functions. So no going to the bathroom, no eating, no sex. All the energy is shunted away from the center of the body and into the muscles for running, for fighting. This is the classic fight or flight response, right? So it makes a great deal of sense. And of course we know, and you can know what I'm getting to, that if you look at people who are depressed, they often look like people whose fight or flight systems are on chronic overdrive. It's a little more complicated than that because sometimes the HPA axis actually then sort of turns itself down. But in general, that's a good first pass approximation. Now, this is the classic fight or flight response. This is what you learn about in med school. What's not taught so much in med school is that there is a very essential immune response that's also involved with this. And the way to think about this, I think, from an evolutionary perspective is until fairly recently, and certainly in most other species, situations that activate fight or flight responses are situations in which you're likely to get hurt. Right? So if you're being chased because you're going to be eaten, if you survive, you're usually hurt. If you're chasing, you're likely to get a hoof in the face. You look at the faces of lions and they're just scarred. And then if you look at social species, especially mammals, they damage each other when they fight to mate. Right? So we know that stress is sort of a shorthand for disruption of the skin. And the skin is the #1 immune organ in the body. One of the chair of anthropology at Emory has done these amazing studies and just recently found that if you look at people about 10,000 years ago, before the advent of agriculture, they mostly died from wounding. They were banging each other over the head, and we know most people, of course, that lived died of infection, and a great way to die, if you've ever read The Snows of Kilimanjaro by Hemingway, guy dies from a scratch, his plane fails, and he's out in the bush, and so he dies from a scratch. This is usually what got people, especially early in life. And so what nature seems to have done is to prepotently prime inflammatory systems so that when they hear the word stress, they turn on so that all the defenses can be right there, ready to fight. And there's beautiful evidence to suggest this is the case. I'm not going into all the details, but I'm claiming this based on a lot of studies. Now, of course, so what happens in depression is this strange pattern that is very, very reproducible. So meaning that not every person with depression has all these findings. But now for 40, 50 years, we know that if you look at depressed people in general, they have these stereotype changes of the stress system. In the HPA axis, I put increased activity here, but in modern times, they'll often have decreased activity if you look at it by measuring cortisol. But what they almost always find is glucocorticoid resistance. So depressed people are resistant to cortisol you know, this is the basis of the dexamethasone suppression test. Do you remember that old dinosaur from, right? That identifies, that identifies people whose bodies, and in particular their HPA axis, are not sensitive to cortisol. Similarly, we know that the immune systems of depressed people are not sensitive to cortisol. And then if you look at what the HPA axis does during the day, if you're healthy, you know, it starts going up in the early morning, like 3, 4, 5, 6 o'clock, because getting out of bed is this hideous stressor, right? And that's almost certainly why the peak of natural death occurs right at dawn. And then if you're healthy, and enlightenment at dawn too, right? Buddha's enlightened at dawn. In the East, dawn is the time of enlightenment. So there's a positive side to stress that I'm not talking about today. We could talk about it at great length, and it's very interesting. I'm talking about distress, not eustress. But if you're healthy, what your HPA axis needs to do is fall throughout the day into the evening. What you see in all sorts of pathologies is that it flattens out. You see this in depression, you see it in fibromyalgia, you see it in obesity, you see it in hypertension, you see it in cardiovascular disease, you see it in cancer, you see it in people that are emotionally repressive. If it occurs in cancer, it predicts death in metastatic cancer, right? So this is a very common, it's not specific to depression, but it is a mark of depression. High cortisol in the evening is bad news. It predicts every bad thing you could imagine and is part of that flattening. And on the other hand, the autonomic nervous system tends to be characterized by increased sympathetic drive, decreased parasympathetic drive, right? So you get an increase of your stress system, and parasympathetic, of course, is very much linked to relaxation, to digestion, to sleep, to socializing, to sex. That tends to go away, right? And interestingly, I can't help these little asides. One of our collaborators, a guy named Steve Porges, told me that if you look at what the parasympathetic nervous system does, one of the things it does is it tunes the 3 little ears in the bones in the ear to be maximally receptive to the frequency of human speech. So if depressed people, you know, if you're ever really depressed and you kind of feel like there's a roaring in your ears, that may not be altogether fanciful, right? If you can't appropriately sort of turn on parasympathetic functioning, you're not able to tune your ears to be maximally receptive to psychosocial interconnectivity. But one of the other things that all these changes do in common is they're all pro-inflammatory. Right? So the neuroendocrine and autonomic changes that characterize depression each share and are all characterized by the ability to drive inflammatory functioning. I'm not going to show you those slides. If I had 2 hours, I'd show you the evidence to support that. It's quite fascinating. But just take my word for it. The evidence is very strong, growing stronger all the time. So what have I said so far? I've said that in response to stress, the brain activates circuits that turn on inflammation. I've also said those circuits tend to be abnormal in depressed people in ways that promote inflammation. So let me talk a little bit about inflammation. And so here we go with just some disconnected organs. You see them here. And let's start with, you know, we all think about inflammation in the immune system as starting with something like a bacteria, which is true enough, right? So one of the things the immune system does, especially the innate immune system, especially classic inflammatory processes, are that they recognize dangerous foreign objects and try to destroy them, right? And they don't do this like the B cells and the T cells. They're not specific antigen-driven. They have, again, and I said this at lunch, but they have these things, I sometimes call them redneck receptors, meaning that they just don't like foreigners very much, you know? They don't like Yankees. You know, like people in something in Georgia, you know, don't like our Yankees. We know something. Your accent's kind of funny, and we don't take to your kind around here, stranger, right? That is really how these innate immune receptors work. Classic ones are things like toll-like receptors. They recognize that this is not part of you. They don't know what it is exactly, but they figure they better start firing at it, right? And to do that, they turn on all these systems like NF-κB within the cells, and then they produce these signaling molecules called cytokines. I just want you to look at some of these names because you're going to see me, because I'm going to delve into this today and talk about our research. TNF-alpha is a primary inflammatory cytokine, IL-1, interleukin-1, interleukin-6, interferon alpha, which we actually study. These guys go all over the brain, they go all over the body, and in the body they do a number of things. The first thing they do is that at the site of infection, at the site of invasion, they make things hot, red, painful, the sort of classic, you know the rubor, dolor, calor, do you remember that from med school? And of course the point of these changes is to just bombard the local area with killing things so you can try to stop the invasion before it gets into the full body. Another thing these things do is they go down to the liver. They commandeer the liver, and they tell the liver to stop making its regular old things like albumin, and start making things like C-reactive protein and various, you know, anti-chymotrypsins. And this is why albumin falls. in people who have chronic medical illnesses, right? One of the reasons is because inflammatory processes turn off albumin. They confiscate liver functioning for their own purposes. Some are pro-inflammatory, some are anti-inflammatory, but that's definitely what happens. And then of great interest to us is that these cytokines get into the brain by a couple of various mechanisms, and they're what make you sick. So next time you get the flu, don't blame the flu symptoms. Don't blame the fever and the chills and the aches and the pains and the anhedonia and the sleep troubles and all that. Don't blame that on the virus itself. Your body sees the virus, it produces these cytokines go to the brain, and they produce these symptoms. You get sick because in the context of pathogen invasion, sickness is an evolved antibiotic strategy. Animals that can mount sickness responses survive infection much better than animals that don't, right? So it's evolved. It's an incredibly conserved mechanism. The problem is, or the challenge in the modern world is that everything I've just told you happens in response to stress, too. And you can show it in a number of ways. This is much of what I do in my life. So about a third of my research is torturing people by stressing them out in one of these GCRCs or CTSIs that we're so interested in trying to establish here with a grant. So here's an example of how we do it. This is a thing called the Trier Social Stress Test. It's simple enough. You take somebody like this poor guy who's sort of unwittingly, he's a research subject. We're drawing blood, we're getting his heart rate, we're having him fill out questionnaires, and he's brought by wheelchair into this room. And he sees these three people in white coats sitting there, and he's told to stand behind a microphone. And then he's told by the person that pushed him in that these are a panel of behavioral experts. And we always find out what people want to do in their life. And so this guy wants to go to medical school. And we say, your job today is to prepare a 5-minute mock job interview about why you'd be a good candidate for admissions to University of Arizona Medical School. These are behavioral experts. They're going to analyze your behavior, but try not to pay attention to that. You'll notice there's a camera. Your performance is going to be recorded for later behavioral analysis, but try not to pay notice. At the end of the task, you'll be given another task, and we tell them that they can sit and they can make notes for 5 minutes, but they can't use them. Then the panel storms out. He does his notes. They come back. The guy in the middle is the only guy that speaks. We train these guys never to smile. You see that look on their face. We tell them jokes. We line them up and work on them until nothing will make them smile. Just flat. This guy says, he says, give us your patient number, please start your speech. And we have various ways of torturing the person. If they talk for 2 minutes and fall silent, this guy in the middle has got a stopwatch for 20 seconds. At the end of 20 seconds, he says, please go on, you have more time. Conversely, if the person's overly glib, the chairman will interrupt and say, are you always glib for job interviews? And of course that bugs people. And then when that's finished, you say, okay, we have another job for you. We want you to take the number 2087 and subtract 13 all the way down to 0 as rapidly and as accurately as possible. Please start. 2087, 2073. First mistake, chairman goes, stop, 2087. Stop, 2087. Don't use your hands. Stop, 2087. Please concentrate. You're making too many mistakes. So if you do this for 10, 15 minutes, blood pressure goes up, heart rate goes up, cortisol goes up. What about inflammation? So let's look at this diagram because you're going to see it a couple of times. Here to the white space to the left is the time before the stressor. The box is that period where they're doing the speech and the math, and then we follow them for an hour and a half afterwards, and we're going to look at how much IL-6, how much of that inflammatory cytokine is made and shot into the blood in response to this very simple stressor. And if you take men who are about 30 on average and they don't have depression and they're medically healthy, what you see is that just a simple stressor like that will increase inflammation over a course of a couple hours, almost double it. Okay, so there's your proof that all of us, that if I put you guys in front of this thing and made you give a speech, especially if you were being frowned at and nobody gave a damn about what you were saying, that you would start driving up your inflammation. But what's remarkable is if you take a same age group of men who are also medically healthy, who have major depression, and in this case a history of early abuse, look at what their inflammation does. It takes off like a rocket. So remember I said that the neuroendocrine and autonomic systems of depressed people are primed to promote inflammation. Well, here is an example of this, right? They come in, they're already higher at baseline, and then, man, after a little bit of a lag, they just shoot off. So here is very powerful evidence that you can think about depression as a state in which not only sort of immunological threats, but environmental adversities or psychosocial are perceived by the body and brain as being so dangerous that they warrant these massive, relatively massive inflammatory attacks. And this or inflammatory activation patterns. And this probably goes a long way toward accounting for why now there are hundreds of studies that are very consistent, not perfect, but amazingly consistent, suggesting that if you take medically healthy people that are depressed, and they can be anywhere from devastatingly depressed to just moderately depressed, and you measure various inflammatory markers at rest in the blood, as a group, depressed people, if these guys are depressed and you guys aren't, their CRP is higher, their IL-6 is higher, their TNF-alpha is higher. And of course, these data suggest you put them in a stress situation and away they would go. Right? So depression as a group condition is an inflammatory state. Now, not every depressed person has increased inflammation. What you see is, here's the range of normal people, and people with depression have a range like this. So there's a dysregulation of these pathways, but at least half of depressed people are floating around in this hyperinflammatory state. This is very important for what I hope to say about nosology if I get there, which is I'm not saying that this is specific to depression. Here's a study we did with the CDC showing that if you look in hundreds of people and you look at chronic fatigue syndrome, and ISF is just one short of chronic fatigue syndrome, and you look at CRP, which is an inflammatory marker, these guys are way higher than people that are medically and emotionally well. We'll just look at this panel for today. So you see increased inflammation with anxiety, PTSD, fibromyalgia, aches and pains, conditions where people are not sleeping well, where they feel hopeless, despondent, anxious. Those symptoms are a signal that on average, people are in a bodily state where they're driving inflammation. All right, that is really the point I'm making here. But that does not prove that inflammation is causing depression, anxiety, or those sorts of things, right? Depression, maybe the inflammation is just like the exhaust coming out of the back of the neuroendocrine system, right? So is there any evidence that inflammatory processes themselves can make people anxious, depressed, irritable, right? And so let's take a look at those data, because that's what I've spent quite a while working on in my life. So let's start with a thought experiment. Let's take this guy. I don't know who he is. I just pulled the picture off the web. Does he look like this because that was, he had some really bad tamales in that house and he just threw up in the bushes? Or does he look like that because he caught his wife in bed with another guy in that house and he's distraught? You can't tell me. We'll never know because we don't know the guy. It points to the fact that if you just take a bird's eye view of the physiognomy of sickness and the physiognomy of depression, there are remarkable overlaps. And in fact, if you line the symptoms up one by one, depression and sickness look remarkably like each other. Psychoneuroimmunology, the second wave of my kind of field, was born with a French guy named Robert Danzer realizing that whether you shot rats full of bacteria or psychologically stressed them, you saw the same patterns of behavior. Even weird things like fever, right? So how many people here consider depression to be a febrile illness? When you see your depressed people, do you think about it? Well, you do, because you've heard this talk 3 times in the last day. Of course you would, now if you got the flu, fever's no big deal, but indeed, if you take a group of depressed people and a group of normal people and you age and sex match them and you get them to wear these rectal probes, which is quite a trick. I started my career with rectal probes and abandoned it because I couldn't get subjects. No problem with the spinal taps, big old needle in the back, but little bitty, no problem, rectal probe. Wasn't happening, at least it wasn't happening down in Georgia. But Marty Zuba at UCLA got people that were very depressed and people that were not depressed to wear rectal probes and showed, as others had before him, that people with depression have elevated body temperatures across the entire circadian pattern. And it follows a febrile pattern where you see, when you're sick, you really get your bad fevers in the afternoon. Now, the kicker of this study, he took all the depressed people, gave them ECT, had them wear the rectal probe again, and swear to God, that's exactly what happened, right? They lined up right with the controls. So he showed that you remove the depression and the body temperature normalizes. This is quite remarkable to me, but as I say, there's a lot of, this is not the only time this has been shown. It's just not known in our field because we don't tend to treat people with depression with nonsteroidals or aspirin. But stick around. I think I'm going to get there, and you'll see that maybe we should be, right? Okay, so that's one line of evidence, is sort of circumstantial. Another line of evidence is the work we've done with interferon alpha, which is an inflammatory cytokine that people give to people that have cancer or hepatitis C, right? What happens when you give people interferon alpha? You ever had a patient that has been on it? Cheery, happy, outgoing, full of energy? No. It in fact produces an astounding array of psychiatric morbidity, from depression and anxiety to suicidal ideation and concentration, memory problems. It produces a gamish of anger, irritability, anxiety, depression, and anhedonia, and then all the accompanying neurovegetative symptoms. And in fact, this is sort of the study that put the field on the map, done just before I came to Emory. Andy Miller and colleagues, they took people who were going to they took absolutely non-depressed people that had malignant melanoma, one little ditzel, otherwise healthy, but it was deep enough that they needed to, in those years, especially go on interferon. Before they started, 2 weeks out, blindly randomized people to treatment with paroxetine or placebo, and then had them stay on it through the first 3 months of interferon treatment. And what you can see is that the poor people that got placebo, even though nobody was depressed at the start, by the time 3 months have gone by, 50% have a major depression. You can cut that to 9% if you pre-treat and continue to treat with an antidepressant. So you give people an inflammatory stimulus, it produces something that looks, smells, tastes just like depression. You give them an antidepressant, it responds just like a just like a depressive episode. So there's a lot of evidence that inflammation is capable of inducing depression. And this has led to a lot of the work that we've done, which is an unbelievably complex study of people that are on top getting interferon alpha and have hepatitis C, and on bottom have hepatitis C and they're not getting interferon alpha, right? So what do? Just real quickly. We assess them before they get any type of interferon. We get 13 hours of hourly blood draws. We get all sorts of assessments. We do CANTAB, neurocognitive testing. We gave them DEX-CRH stimulation tests to look at cortisol sensitivity. We gave them these TSSTs. Remember that little stress test I showed you? We did neuroimaging. We got 2 nights of sleep assessments with polysomnography. And then, when they got their first dose of interferon, we studied what their body did to that first dose. And I don't think I have a slide, but I'll tell you that there are some inflammatory chemicals that predict at a correlation of almost 1, 0.9. I can measure inflammatory response to interferon alpha and have a 90% chance of guessing whether she's going to be depressed 2 months later, right? So we did that, and then we followed people every month, here at 4 weeks, here at 8 weeks. And then at 11 weeks, we actually got spinal taps on these people. And I wish to heck we'd gotten spinal taps in the beginning, but the boss at that time was too chicken to do it. And then we'd repeat the whole thing again. All the sleep, all the blood, all the everything after 3 months. And then we follow them. So one of the first things we found was that if you take people, this is actually from a malignant melanoma study, but if you take people that are getting their very first dose of interferon alpha and measure how their stress system, how their ACTH and cortisol responds, what you find is that if you then look at who is depressed and who is not depressed 2 months later, if you are somebody wandering around who sees an inflammatory stimulus with a massive stress response, you will get depressed 2 months later, even though you're not depressed now. It's like a crystal ball. Right? So the red are the people that went on to be depressed, the black are the people that didn't get depressed. So we know that there's a sort of cross-reactivity, that these systems that we think of as often being primarily psychological are activated by inflammation, and the more they're activated, the more depressed you'll be. Maybe this explains why people that are anxious and nervous going into medical procedures and into illnesses have a much higher rate of developing depression. Maybe it's not all in their head, maybe it's partly in their body. You see? So maybe people that have sensitized stress systems, they freak out when they see a psychological stress, like the men with the early abuse I showed you in interleukin-6. But maybe they also do the same thing in response to the types of inflammatory processes that are the bedrock of most modern illnesses. So you can look at people's stress responses to a first dose of interferon and predict depression. What if you took them and put them in a psychological stressor instead of an immunologic stressor? What if you gave them that little stress test, that nasty thing I told you about? And what if you looked at people that were about to get interferon? Do their responses to the stress test predict whether they're going to get depressed or not under an inflammatory challenge? So here's cortisol, and it's sort of the same idea, right? Here's the time before the stressor, there's after. The red line are people that were depressed after 3 months of inflammatory exposure with interferon, and the black are the people that did not get depressed. So here you see a different pattern that's emerging, that hypocortisolism in response to stress may be actually more of a risk factor than hypercortisol responses. Here is inflammation. So now it's the opposite. People that got depressed 3 months later had much larger inflammatory IL-6 responses, not to interferon alpha, but to a TSST, to a psychological stressor. If you look at the area under the curve, it's pretty impressive. They just, they come in higher and they make more. So it really looks like, again, if you're somebody who has a big inflammatory response to a psychological stressor, you're not going to fare well if you're under the types of inflammatory stress that are part and parcel of depressive illness. So this is the data I showed you with first dose. If you just look at this delta P38, that's really interesting. You look at depression scores. This is depression scores after 4 weeks. The more inflammation you make in response over the first couple of hours after that first shot of interferon alpha. 4 weeks later, man, that is a heck of a correlation, isn't it? Right? It's pretty amazing. So we know, I mean, this has really told us that people are always looking for biomarkers and things. Here's a pretty interesting biomarker in terms of a risk factor. And P38 is emerging as a really interesting system in depression. Then if you look 12 weeks, so now we've changed our tone. Now we're asking ourselves, if we look at people at 12 weeks, half of them have gotten interferon, half have not. What does it do, in this case, to this inflammatory cytokine? It's a receptor for that TNF-alpha. Well, look at this. The people that got interferon are on top. The controls are on bottom. Now, when they started, they were like this. Okay, I didn't show you that. Look at the standard errors here. This, there's not a lot of overlap. And in fact, if you look at people in this study, if you look at that same inflammatory marker, what these show is that the more your inflammation goes up over time in response to a stimulus like interferon alpha, the more depressed you're going to be and the more fatigued you're going to be. Right? So this is one pathway by which an inflammatory stimulus, probably like a virus, because remember interferon is what your body produces when you're under especially really bad viral infections. The more you respond to that with a heightened inflammatory response, the more depressed you're going to get. Okay, so that's one pathway by which they're linked. But let's talk about cortisol. So I've already showed you data that if you respond with a high cortisol response to a first dose of the inflammatory stimulus, you get depressed. We know, and remember I said that the flatter your cortisol slope is, the worse it is for you, right? So here's data, an old study, this is from Eugene Pakel, just showing that depressed people, not only in the old days especially, they had higher levels of cortisol across the day, but if you look from the peak to the trough, instead of going like this, it's more likely to go like this. And we wondered whether inflammatory mechanisms, just showing that the peak is, the difference is just a flatter slope. We wondered whether inflammatory processes might have something to do with this. I've already told you that having a flat slope is bad. So we looked at whether interferon flattens the slope. And what this slide shows is interferon does this. Right? So the people that were in the control group, the first time they came into the hospital, they're a little bit nervous and stressed out. The second time they come in, they know all the nurses, their slope got steeper. And so they really went like this, flattened out, and these guys got steeper. And what this shows is the flatter your slope got, the more depressed you got. So another way that inflammation, remember I'm telling you that inflammation is activated by stress as much as by something like interferon. When inflammatory pathways are activated, they disrupt circadian patterning of cortisol. The more they do that, the more depressed you're going to get. And this is happening in time. We're watching this roll out, right? This is not cross-sectional. This is delta symptoms to delta cortisol. How much time I got left?
2 minutes.
Oh, I'm not going to make it. Okay. Well, I'll just sort of stop wherever I stop. But remember that I said that glucocorticoid resistance was a major piece of depression, that people with depression have these dexamethasone non-suppression. Here what we found was that inflammation makes you resistant to cortisol. And the more resistant it makes you, the flatter your slope gets. So we now think that what's going on is that in vulnerable people, inflammation makes them insensitive to cortisol, and then that then leads through probably glucocorticoid-mediated mechanisms to flattening your slope, which is bad news. Now, interferon alpha also screws up your sleep. So what happens here is when you're under chronic inflammatory burden, you don't sleep very well. You wake up all night long and you don't get much slow-wave sleep. And the more that happens, the more depressed you get. And the more that happens, the more your cortisol flattens. So it's very interesting that there's these circadian patterns that are disrupted by cytokines. We see exactly the same thing in depressed people. So here just showing the correlation between how flat your slope gets of cortisol and how poorly you sleep. And also, the more poorly you sleep, the worse you do on neuropsychological testing. Right? So you think of people that are in inflammatory states, like pre-dementia, things like that have problems with neurocognitive functioning and psychomotor slowing. Here's evidence that the HPA axis is some sort of transducer, or it's on the pathway between inflammatory signaling and these very, clearly replicable psychological things or neurocognitive things. Let me just say a couple of things about treatment. I'm going to skip the nosology. You're not going to hear about why the DSM is totally wrong. I'm sorry about that. Here are one of now a number of studies showing that if you take people that are perfectly healthy and have major depression, if you randomize them to an antidepressant plus placebo versus an antidepressant plus a COX-2 inhibitor, They have deeper antidepressant responses with COX-2 inhibitor on board. There's data showing, the data is not randomized, so it's not as strong, but there's evidence that aspirin has antidepressant effects and actually can take people that are SSRI non-responders and convert them to responders. And then there's these very interesting studies. You guys all heard of a drug called Remicade or Enbrel, you know, these TNF alpha blockers they use for like inflammatory bowel disease and rheumatoid arthritis. There was a big study where half the people, these are all people with psoriasis, half of them got placebo, half of them got, in this case, etanercept, Enbrel. And they actually looked at depressive symptoms. And what they found were this was not a very depressed group, but the people who got the Enbrel had an antidepressant response. And it wasn't correlated with improvement in their symptoms. It didn't matter how much their skin cleared up. This led us to actually get a grant. We're now giving Remicade, this big TNF blocker, to folks that are healthy but depressed. We don't know the answer yet, but if it works, it'll be quite remarkable because it doesn't get into the brain. So A, it's a completely novel mechanism, and B, it shows you can treat depression in the body, that you don't necessarily need to access central nervous system. People have no side effects with it. They don't know if they're on it or not. So if it works, this may be the dawn of antidepressant strategies that dodge all these nasty CNS effects by signaling the brain through the body. And then finally, one of the things we're on the verge of doing is it turns out that certain bacteria that were once very prevalent in the human environment and that are now absent have profound anti-inflammatory effects. And this may be why autoimmune diseases and asthma and things like that are so high in part in the modern world, is because we're separated from organisms that over time co-evolve with us to down-regulate inflammatory signaling. And they've given these, colleagues of ours have given these organisms to people with cancer and shown, first off, in fact, that in people with certain types of cancer, they may prolong survival. But definitely, they have this very strong antidepressant, anti-anxiety effect. So again, it's very consistent with this idea, and I'm going to stop here. I won't tell you about the compassion meditation. But in fact, we've also done meditation studies to show that if you train people to take a less stressful view of their interpersonal relationships, you can turn down inflammatory responses to stress. And so it's not just pharmacologic, there are behavioral strategies that have these same patterns and that, you know, obviously would have some really interesting health implications. So with that, sorry I didn't get through the whole talk, but I'll stop. Maybe we take questions for a minute or two.
Superb talk. One question that's not clear to me. I think you made a convincing case that inflammation is playing a role in depression, but how much of depression is really influenced by inflammation? In other words, if you take 100 people with depression.
Yeah, exactly. So that's a great question, and I wish I had like a splay to show you like what studies find. The answer is that in our studies of treatment-resistant depression, about 70% of people have CRP levels that are in the high range, high normal range, right? Compared to, 30% in the general population. So it's not 100%, but here's the wrinkle. And this is, so 2 days ago at 5 o'clock in the morning when I got up to try to answer my 100 emails that I hadn't dealt with because of the fun I've been having around here, one of them was from an old colleague of mine at UCLA who abandoned psychiatry to become this mogul investor in sort of bio startup things. And he wanted to know what I thought of this company that maybe had a biomarker for diagnosing depression. And I said, I think that's the biggest waste of time in the world. Because first off, what if somebody was just weeping and crying and wanted to kill themselves and their biomarker was normal? Would you tell them to go out and no problem? What if they had a horrible biomarker but they felt great and were doing great? Would you put them on an antidepressant? So, but the point is, the reason that biomarkers are never going to be more than sort of statistically correlated with even outcomes is because one person's inflammation is not another person's inflammation. So think about interferon alpha. What's cool about it is we give all these people the same dose, milligrams per kilogram, right? So they're all getting the same inflammatory push, and some people get very depressed and some people don't. And so what that says, of course, is that there are underlying vulnerabilities. Inflammation is like stress. It's extremely nonspecific. It causes all the modern illnesses, right? Stress causes depression. Well, that tells you that if you understand what stress does, you might understand how the pathophysiology of depression develops. But not everybody gets depressed in response to stress. Not everybody gets response. But what's remarkable is the same pathways that appear to be in disequilibrium in sort of psychogenic depression are the same pathways that set you up to get depressed when you're having an inflammatory burden. So How I would look at it is, and this is, and Miller and I, the other, we argue about this. He's more of a biomarker guy, but my response is, the problem is that if you are a very resilient person and have your inflammation up here, you might be fine emotionally. Now, if your locus minoris is in your vasculature, you're going to have a heart attack, whatever, or you're going to get diabetes. But if you've got a lot of emotional resilience, on the other hand, if I'm just ready to fall apart at the smallest thing, this level of inflammation. We had an argument about whether we should only do it in people that had elevated inflammation. I've always said no, because we don't know ahead of time what all these vulnerability pathways are. So the way I would look at it is that if you take this vast interconnecting mind-body network that at the end of the day is going to have a lot to do with astroglial, neuronal, microglial, oligodendrocyte interactions. I didn't even go there today, but there's a big CNS story that this is all pointing to, and has to do with how these elements interact and how they do or do not let signaling from bodily macrophages affect their functioning. I mean, we're skimming around the surface in this little talk, but the point being that these systems are all interconnected, and in people that are in one of these bad states, they tend to run these systems in certain ways. But there's a lot of variability, and nobody runs all the systems the same. These are all probabilistic things. Depression is a probabilistic outcome from probabilistic systems. And so this is a very long answer to your question. This is why I get criticized, because I don't let people, I'm sorry, I didn't mean to go so long. But you've asked the key question, and the answer is, it depends what you mean. Once you pull the string, you're no longer talking inflammation. You're talking about NMDA receptors and non-synaptic NMDA receptors on astroglial cells, and how that drives BDNF or turns BDNF off. And it's all part and parcel of the same thing, and it's all affected by inflammation, which we didn't understand when we started. That was one of the gifts of inflammation, was we realized that we weren't looking at a discrete thing. We were looking at this entire system.